This chart plots the global incidence rates of Hodgkin lymphoma against patient age. The data shows a distinct bimodal distribution, with a massive primary peak occurring between 15 and 19 years old and a secondary peak after 50. In that adolescent bracket, Hodgkin lymphoma accounts for over 25% of newly diagnosed cancers, making it the most common malignancy in this age group. Clinically, the disease presents as the progressive, unicentric enlargement of lymph nodes. It arises in a single focal area and follows a highly predictable, contiguous pattern of spread to adjacent lymphatic regions. But the physical bulk of these expanding nodes conceals a biological paradox. In most solid tumors, the mass is entirely composed of rapidly dividing cells. In Hodgkin lymphoma, the actual malignant cells constitute less than 1% of the total tumor volume. Moving into the microscopic space, the true architecture of the disease becomes visible. A single anomalous cell rapidly swells to massive proportions, measuring up to 45 micrometers in diameter, physically displacing thousands of tiny normal lymphocytes around it. This massive multilobulated anomaly is the Reed-Sternberg cell. Its presence is the pathognomic hallmark required for a diagnosis of classic Hodgkin lymphoma. The remaining 99% of the tumor mass surrounding it is entirely benign. It is a reactive inflammatory infiltrate, composed of normal lymphocytes, macrophages, plasma cells, and eosinophils. To understand Hodgkin lymphoma, we must view it as an architectural disease. The Reed-Sternberg cell survives by actively engineering a localized inflammatory microenvironment around itself. That engineered environment ultimately dictates both the patient's physical symptoms and their statistical chance of survival. The Reed-Sternberg cell originates as a crippled clonal germinal center B cell. Through somatic mutations and complex chromosomal rearrangements, it loses most of its native B cell gene expression and function. Looking at this simplified cell surface model, we can map its unique immunophenotype. The cell sheds standard B cell surface antigens like CD45, CD19, and CD20. In their place, it robustly expresses and locks in CD30 and CD15. This creates an immediate, severe biological problem. A crippled B cell losing its native genetic expression is programmed to trigger apoptosis. The cell circumvents programmed death through a molecular rescue mechanism. Inside, a constitutive, unregulated activation of the NF-kappa B pathway acts as a permanent blockade against incoming apoptosis signals. In many cases, this survival mechanism is outsourced to a viral pathogen, demonstrating particularly high prevalence among young children and patients in underdeveloped nations. Epstein-Barr virus, or EBV, is heavily implicated. The virus integrates its genome into the cell, introducing latent membrane protein 1 into the signaling network. LMP1 interacts with tumor necrosis factor receptor-associated factor 1, upregulating the NF-kappa B pathway to maximize gene expression. EBV genome fragments are found in up to 50% of Hodgkin lymphoma specimens. The virus provides the exact genetic rescue and repair machinery needed for the crippled cell to evade apoptosis. This viral molecular engine locks the Reed-Sternberg cell into an immortal, hyperactive state, fueling the continuous cytokine production required to engineer the tumor's microenvironment. Once immortalized, the hyperactive Reed-Sternberg cell begins secreting a highly concentrated storm of cytokines. The primary output includes interleukin-1, interleukin-6, interleukin-5, and tumor necrosis factor. Cytokines rapidly recruit benign cells, eosinophils, macrophages, and lymphocytes, forming a dense cluster. This combination defines the 4 Wu subclassifications. The most common, nodular sclerosis, features thick collagen bands dividing tissue into isolated nodules populated by lacuna Reed-Sternberg variants. By contrast, the mixed cellularity subtype lacks these rigid fibrous bands, presenting a chaotic, heterogeneous mixture of eosinophils and histiocytes. This subtype exhibits a strong correlation with Epstein-Barr virus integration within the tumor genome. Parallel to these classical subtypes sits a distinct histological entity, nodular lymphocyte predominant Hodgkin lymphoma, or NLPHL. NLPHL relies on scattered popcorn cells instead of classic Reed-Sternberg cells. Unlike classical counterparts, popcorn cells retain their B cell antigens, testing positive for CD20 and CD79A, while completely lacking CD30 and CD15. These subtypes provide visual readouts of how the mutated cell's cytokine storm physically weaponizes the patient's immune system to construct its structural mass. As the microscopic architecture expands, it dictates the macroscopic clinical presentation. Patients primarily present with painless swelling of superficial lymph nodes, most frequently involving the cervical and mediastinal regions. A mediastinal mass is bulky when its maximum width exceeds 1/3 of the internal transverse diameter of the thorax on an upright chest radiograph. The same localized biology drives systemic presentation. As cytokines accumulate in the tumor microenvironment, they spill into the systemic circulation, triggering constitutional reactions known as B symptoms. The presence of B symptoms is strictly defined by 3 criteria: unexplained weight loss over 10%, unexplained fevers exceeding 38 degrees Celsius, and drenching night sweats. The Ann Arbor classification maps this spread. Stage 1 involves a single lymph node region. Stage 2 involves multiple regions on the same side of the diaphragm. Stage 3 crosses the diaphragm, and Stage 4 represents disseminated spread into extralymphatic organs. Fluorodeoxyglucose positron emission tomography, or FDG-PET, serves as the gold standard imaging modality for this staging. Its high sensitivity for metabolic activity frequently obviates the need for invasive bone marrow biopsies. Accurate staging measures the exact architectural footprint of the disease. This provides the strict anatomical map required to balance curative chemical therapy against the risk of devastating long-term toxicity. Treatment protocols are sharply stratified by this map. For stages 1 and 2 without B symptoms, the standard of care requires brief, limited systemic chemotherapy, typically 3 cycles, which is then followed by precise, involved field radiotherapy. Advanced stages, or early stages presenting with B symptoms, mandate intensive systemic intervention. This requires 6 to 8 cycles of multi-agent chemotherapy regimens like ABVD or COVP, often augmented by radiotherapy for bulky disease. The efficacy of these regimens introduces a difficult survivorship paradox. The cure permanently scars the physiological landscape, leaving a toxic chemical burn that expands across the patient's remaining lifespan. Today, Hodgkin lymphoma is considered a highly curable disease. Consequently, clinical oncology is forced into aggressively managing the lifelong iatrogenic toxicities caused directly by the curative agents themselves. This timeline illustrates the long-term risk profile for survivors. Secondary hematological malignancies, primarily acute myeloid leukemia linked to alkylating agents, spike early but plateau 10 to 15 years post-therapy. The risk for secondary solid tumors continues to climb indefinitely. Specific organ systems bear the brunt of specific agents. Survivors face severe cardiotoxicity driven by exposure to doxorubicin and thoracic radiation. Pulmonary fibrosis is a late-stage complication inextricably linked to bleomycin exceeding 200 units per square meter. Gonadal toxicity presents another critical threshold. Infertility and azoospermia are heavily dose-dependent on alkylating agents. For males, cumulative doses of cyclophosphamide greater than 9 grams per square meter reliably result in permanent infertility. The modern clinical management of Hodgkin lymphoma relies on a high-stakes calculation. It is a precise titration of chemical and radiological warfare, designed to silence the Reed-Sternberg cell's subversion while painstakingly preserving the patient's lifelong physiological architecture.